Yeah, I'll give it to 32. It's quite a number still dialing in.
So already I can see the variation in exactly what you described, Malcolm, around some people from hospices or third sector organisations, people from car distributors, and the highlight so far is Mr. Equi. I need to discuss with Mr. Equi the fact I dated my now wife at that Equi's ice cream for probably about 4 years. We used to drive from Airdrie to Equi's ice cream. That probably is the reason I'm now married, his ice cream.
Good for you.
Thanks for joining us, David. Morning, everybody. Thanks for joining us. If you want to put on the post on chat where you're dialing in from and your organisation, that'd be fantastic. Thank you. So we're going to get started. Thank you so much for joining us. I'm delighted to welcome Jason Leitch, Professor Jason Leitch, National Clinical Director from the Scottish Government, and I'll hand over to you in just one moment. We're just going to keep everybody on mute today, and if you want to post any questions, just put them in the chat box. We'll also be recording the session and we can share that with you afterwards. So I'm just going to hand over to my colleague Malcolm Cannon, who's the National Director for IoD Scotland, and he'll be asking the questions. Thank you.
Well, thank you very much, Kirsty. Good morning, everyone, and a huge welcome and a massive thank you to Professor Jason Leitch, the Clinical Director for Scotland. We'll get on to some questions very soon. We've got a few questions. I'm sure we'll pick some questions up during the session as well. It's very good of you to come on today because I know you've got a very busy day ahead of you and a little bit of a varied day ahead of you. Can I just ask the first question? In terms of setting context and landscape, we've got Gregor Smith and yourself with two different titles. Can you just say how that works in terms of separating responsibilities?
Yeah, so it's changed a little bit in the last few weeks, where we've kind of fallen into different but connected pipelines, probably. So I'm a dentist who then did head and neck surgery, oral surgery for 20 years. So I was a consultant surgeon. A slightly odd route for a dentist. Most dentists end up in the high street, but some of us end up in more hospital-based specialties. So I, long story short, did surgery. So I did lots of facial trauma, lots of cancer, became a consultant in the west of Scotland after a number of years. A little bit bored, went to America, did a public health degree in the States, looking for something else to do. My wife and I moved to Boston and did two things there, which are now relevant to this conversation. I did a master's in public health. Who knew I would then be in the center of a global pandemic? It was in the early 2000s. And I also worked for an organization, not for profit, as they would call it, in Boston, who do process change and improvement for healthcare organizations. So I learned what people on this call would know. I learned about process change. I learned about W. Edwards Deming. I learned about data and run charts. I learned a lot of engineering stuff that they don't teach healthcare workers. Came back, got a part-time job for the government, part-time clinical, led safety work, quality work inside the Scottish Health Service. Got a bit of a reputation for improvement and communication, and eventually went full-time when I became the National Clinical Director. And to answer the fundamental of your question, we have 3 senior clinicians in the Scottish Government, sharing but with separate policy responsibility. We have a Chief Medical Officer who traditionally does doctor leadership, public health leadership, and bits of the puzzle. We have a Chief Nurse who does nursing leadership and traditionally also does healthcare-associated infections and infection control. And we have a National Clinical Director who in the main does quality and safety of the delivery system. So I have a responsibility for, in conventional times, how we keep the system safe, whether that's in a GP practice or in a hospital, and a global network to try and help us learn. I also have a bit of responsibility for that. And that process improvement piece that I brought back from the States, I also now do that across Scotland's prison service, across Scotland's third sector, loads of other places. And then the pandemic came along and we had to kind of distribute the work. And I became a little bit of the front guy because I'm not scared to talk out loud. the First Minister and the Cabinet Secretary and I decided that we needed clinical voices as well as political voices. We thought it very important. And you can see how different countries do this differently. That's a judgment. You can decide if that's right or wrong. So I don't answer the political questions, but I try and share the public health truth as we know it and try and help the politicians with that communication. That's roughly how we end up here, David.
That's a really useful explanation. Just touching on that, seeing how other countries do it, does the clinical side of it also learn from good and bad of how other countries are handling the public health crisis that we're going through, as opposed to the political side that we see?
Hugely. In fact, probably easier for us than it is for the politicians. It's a relatively small network. The senior executives of health systems is not a big group, so we know each other, literally know each other. I mean, it's like all things. These things are often relational. So I have spoken to the people running the Alaskan health system and getting them through the pandemic because I know them, and we have contacts in the main in the English speaking world, probably more solid. But I have a lot of pals and colleagues, for example, in Scandinavia, running some of the best health systems in the world. So I've spoken to the Swedish chief execs, the Danish chief execs, and those examples and wisdom is helpful. You have to be careful with country comparisons. You've got to be so careful. And whenever I'm on the telly or on social media and somebody puts us up a simplistic table of country death versus one variable down the right-hand side, it's usually nonsense. But there are legitimate questions to be asked about how countries respond, how countries responded, and how countries will respond in the future. And I think we can learn a lot from states in America, from Spain, from Italy, from Germany, and there are pieces of that puzzle. So Scotland is special, but so is Austria. I mean, they're just special in different ways. So we have higher inequalities, we have more poverty, we have higher density of populations in two big cities, and then it spreads out rurally. So Orkney, for our friend who was on, looks very, very different from Sauchiehall Street. So we got to apply to our demographic, but you can absolutely learn from the rest of the world. There are formal networks of that. So quite early on in this, we had a delegation from Wuhan, China, who we spent a lot of time talking to about how they did intensive care, what they saw in the patients, exactly what you would expect. And we don't do that live on the telly, but my intensive care doctors were trying to learn from that as we go through the whole thing. And then vice versa, we go back now and learn in the other direction.
I think actually Sauchiehall Street looks exactly like Orkney at the moment.
It certainly should look like Orkney, doesn't it?
Yeah. In terms of, you just mentioned levels of poverty. Do you think that is one of the driving factors in the differential of death rates and infection rates?
I do, for sure. Unfortunately, infectious disease for 200 years has had a higher impact on poorer people, wherever that happens, whether that happens in Nigeria or in Scotland. And if an infectious disease likes poor housing, it likes obesity, it likes crowded family rooms, everything about poverty, viruses love. So if you live, forgive the caricature, but if you live in a 4-bedroom detached sandstone villa, social distancing, self-isolation, everything we're asking you to do, although not easy, and I'm not diminishing the challenge of these public health measures, it's somewhat easier than it is in a 1-bedroom house with 3 kids on the 37th floor. So all of that together makes the risk of catching the virus higher if you're poor, and the risk of severe illness if you're poor, because in the main, the poorer in society have more chronic disease, have more addiction, have less access to quality healthcare, have less access to quality education. So all of those things added together, unfortunately, Scotland has never been able to, although fantastic work is going on, has never been able to remove that structural inequality to an extent where the disease wouldn't affect. So everything we look at, from old diseases to this one, will I'm certain show a curve of impact based on social demographics. That doesn't mean that wealthy, middle-class 35-year-olds can't get the disease. So it's important not to think this is a poor person's disease. It's not. It is no respecter of ethnicity or society in any way, but your risk factors increase as your poverty increases, roughly.
Absolutely. And I'm sure, as you just sort of hinted on then, population density is also related to poverty in many cases where people are crammed together, either in high-rise or in many people to one room.
Yep.
Looking forward, as we come into restart, certainly through reset to restart, how do we minimize our risks that we either don't repeat our same problems we had at the beginning, and how do we come out of this as quickly as possible?
So there's loads in there. So stop me if it's too long. So the best way of framing that is the WHO's 6 steps to removing lockdown. That's the best frame I have found. And we are using those 6 steps as our assessment about how you do that. So when the First Minister asks for advice about what to do next Thursday on the next review date, we are basing that advice on those 6 steps. And then, of course, there's a judgment layer. Nobody elected me. I don't get to choose. I get to advise. So she and the cabinet get to choose. It's very, very important. I keep having to say it when I'm on the telly getting a hard time. That say, I'm telling the truth. The judgment piece is for other people. That's for in a democracy, that's how it works, whether you like it or not. So the 6 steps are relatively straightforward, and they apply to this crowd, I think, quite neatly. And some of them are very, very applicable to this crowd. So step number 1 is suppress the virus. So get the R number down, get the total incidence down, get the prevalence of the virus down. So just literally suppress the virus. And that's what you've seen us doing for 10 weeks. Number 2 is have a test and trace system in place that's working. And that's now Scotland's test and protect system. Been up and running for a week. We've got 681 positive cases. We've got 481 of them completely traced and finished. We've got 200 of them ongoing because whenever you take the data out, of course, there are active cases, inevitably. We've traced and isolated a whole load of hundreds of people from those. So we are now confident test and protect is working. We're not entirely confident that it's finding all the positive cases because it needs volunteers. People need to come. Number 3 is suppress outbreaks in institutions. This is hard. So that's care homes, prisons, hospitals, children's homes, anywhere where people live together. And the virus loves that. Warmer environments, excuse me, people close together, particularly vulnerable individuals with other disease. Remember, the average length of stay in a care home in Scotland is 18 months. So people don't go to care homes for 5 years to live a happy life. They tend to go to care homes at the end of their lives or near the end of their lives. So that's not an excuse for giving them an infection. Please don't misunderstand me. But it is a way of cohorting our individuals in one place. They're the 3 public health ones. Then it gets a bit more societal. So the getting your workplaces ready is one of them. So you can't move out of lockdown unless manufacturing knows what to do, unless shops know what to do, schools know what to do. So that's about all the individual elements of guidance which your organisations and organisations like the Institute of Directors are trying to manage for us, the construction industry, the 5 steps back to public transport, all of those other elements. And then I forget number 5. It'll come back to me. Number 6 is where I think part of my job is, and that's communicating with the public. That's engaging and communicating with the public. Because if the public don't know what to do, you can't move out of lockdown. So what is number 6? That's weird. It'll come back as we're talking. But the framing of those elements, I think, helps us both advise the First Minister, but it also helps businesses, organisations, third sector groups to think about what that means for them. So the first 3 you can't really help me with, other than follow the rules and make sure your employees, your partners know that test and protect is crucial. So please get a test and please isolate if you're told, and make sure your workers know that they don't have to come to work if they're self-isolating. So there are elements for business, but then after that, it's really important that the messaging goes out to this sector and you behave responsibly inside your sector. So that could be as simple as alcohol gel when you walk into the ice cream store, or it could be plastic sheeting in the manufacturing sector. It'll have to be adapted for your individual place.
Someone just said what stage 5 is.
Well done, Susan. It's actually importation of cases, they call it. So number 5 is importation of cases. So that is why quarantine at airports, quarantine at ports, etc. So it's about, if you get suppressed, don't let more in, because then you'll get outbreaks again. That's number 5. Well done, Susan. Thank you.
Just shows people are listening as well. That's wonderful.
At least one person is listening.
No, that's a really clear set of 6 steps. It's very clear that the 3 are effectively your responsibility. Well, all 6 are all of our responsibilities, but we can help with those 3. I think it's really important for the people on the call and the people who will listen to this later, in terms of how businesses can help. Now, obviously, we're involved heavily in the restart structure for the various sectors, and I think that's really important because we're acting as a voice for the business representation that we have. One element of that, and it's key and it's very, very vocal today, is about the 2-meter distancing.
Yep.
Could you, or would you sort of give your thoughts on that and the difference between that and 1 or 1.5 or 1.4 or whatever the various approaches are?
Yeah, one of the amazing things about a global pandemic, and there's nothing good about a global pandemic. Global pandemics are evil, and they take life, and people live with the misery of it for the rest of their lives. So even the people surviving intensive care will be rehabilitating for many, many years to come. It's absolute misery. However, inside that pandemic, some good comes, and one of the things that's happening is the population is learning about public health. And one of the things you have to learn in public health is it's not like asthma. It's about risk. So everything you do, there is no risk-free path here. So coming in or out is not risk-free. So coming out, you're going to choose a variety of paths, all of which contain risk. And you can see us trying to reduce that by shielding some of the population, by thinking about schools on a staged basis, whatever example of whichever sector you want to take. And the headroom that we have inside the suppression is for the First Minister and the Cabinet to decide how to use that headroom. So I've had conversations this week with the travel industry, with elite sport, with schools to say, hold on, we decide that early years is more important than universities. Now that, when you say that sentence out loud, half the population think, whoa, but that's the kind of judgment you're making. The politicians are having to decide, is it more important to get nursery schools back or fourth-year medical students? And it's not quite as binary as that. And that then takes us to the risk of the public health interventions. So we know that droplets, in which the virus is held, need to spread from person to person. So if you are facing that individual, that droplet can reach you. The WHO say you should be at least 1 meter apart, because the evidence is that for coronaviruses, of which there are many, this is just a novel new one, unfortunately, it take at least a meter away. It's quite hard, if you're not shouting or sneezing or coughing, for that droplet to reach you. 2 meters is a margin of error that we have decided as advisors in most of Europe and Scotland. We have decided is a margin of error that we are comfortable with, and that's what we've stuck with. I think as we suppress the virus, that advice might vary and change, but it will not be binary. It will encourage. So I had a conversation with the people who do Scotland's railways a couple of weeks ago. And one of the things they're getting annoyed with is they haven't been able to do upgrade works on tracks. So I asked them to describe to me how that is physically done. And it turns out you can do that back to back rather than facing each other. You don't have to have 2 guys or women facing each other to lift the track. You can do it in reverse. That's risk-free. So when you start to think about at what you're actually doing, the 2 meter rule is one element of it. It's very important that time is incorporated into that risk. So if I very slowly jog past you in the street at a half a meter, you're not going to catch the virus. If I stand and talk to you at half a meter and I have it, you're very likely to catch it. So we've got to think sensibly, and 2 meters at a population level is where we have landed. I don't today anticipate that changing soon, but if you have me back in July, you may find I'm saying the science has moved on, our numbers are so low, here's what we're going to do next.
Well, that's just to devil's advocacy, I suppose. In July, let's assume that the numbers have reduced. Reducing that distance, the risk is still exactly the same to catch the virus. What you're saying is the concentration of numbers of virus would not put a stress on the health service. Is that what it's
and you make a judgment. I mean, remember, we live with infectious disease all the time, and we don't tell you to self-isolate.
No.
So we're not going to tell you to self-isolate for flu, for normal flu. So the world lives with infectious disease. Flu kills people. So society has made choices based on risk, based on public health, to go about its business as normal and hug each other normally and shake hands while it has influenza. So there will have to come a point in the future where we decide as a society, as a world really, that we're going to now live with coronavirus. But we're not there yet, because there's no vaccine, no treatment, and it is killing the vulnerable. So we will get to a point where there are other things that happen. So we will get to a treatment, probably. I don't know when, and I don't know what it is. We will probably get to a vaccine because the virus doesn't appear to be mutating in a way that we won't be able to catch up with it. I don't know when that will be. I hope this year. That most of the sensible scientists think first half of next year. The optimists think maybe this year. So once you start to get that, and you can protect the vulnerable in a different way, now you can start to get society back to normal.
And do you think this distancing, physical, social distancing, will be in place as a recommendation until such time as we have a vaccine? I
think the only way to remove the physical distancing is to remove the virus to such an extent that it won't be affecting and killing particularly that high-end group. And the reason it's not doing it just now is we're in lockdown, and most people are at home, and the number, you can tell from the contact tracing, the number of contacts per index case is 1.1. So in peacetime, so if we do sexually transmitted diseases or we do measles with contact tracing, the average number of contacts in a 48-hour period for the population is 20. So we've heavily reduced that with the interventions we're doing, because we've got think yourself, how many people have you been close to for more than 15 minutes at 2 meters in the last 48 hours? For me, it's one. It's only my house. It's only my wife. Nobody else. So my contact trace would be 1. So if we behave, the contact tracing will work and we'll get out the other end. So if we got the numbers so low, like New Zealand's a slightly special case, and we can discuss that if you wish, but if we got to New Zealand, then you can then remove the social distancing. The way to get there might be a vaccine and or a treatment, because with our demographic and our access to the country and our big airports and the way the UK is designed compared to where New Zealand happens to land is slightly different. So we are not confident as advisors that we can get this to zero. We think we will need medical and healthcare help to get to zero.
Your point on New Zealand, is that because it's not a through way to anywhere else? It's an ultimate destination, if at all. Well, the likelihood of transmission from other countries is very low.
So they had a number of advantages, and good luck to them. And I've got pals there who run the health service, and they've played a blinder. They were later in the epidemic, so the later you are, the more you've learned. So always, they didn't have a Northern Europe hotspot that flew in, which is what happened to us. The research this week suggests we had 113 entry points of travellers from principally Northern Italy and Spain in the spring break holiday, lots of skiers from northern Italy who brought the virus back with them through no fault of their own. I mean, they didn't do it deliberately. And we got some of the busiest airports in the world, and they're maybe not in Scotland, but they're across the whole of the UK. And then we're this very, very open society where people travel around. New Zealand is an ultimate destination, as you say. They closed to international travellers pretty quickly because they had seen it coming. They had early warning, and it's easier for them to close to international travellers than it is for us. They also have a very good public health system. They don't have some of the structural inequalities that you and I that we described just right at the beginning. So country comparisons are difficult, but there are some obvious things that are different in the UK response compared to the New Zealand response. But we will learn as we go out how that might work. You can see the headline this week is New Zealand back to normal. Well, it's back to normal, but still shut.
Yeah.
So they're making choices in there about what they do with their economy and what they do with their public health. So they're still making decisions about how they live.
Yeah. We've got quite a few questions coming in, but I want to, there's another couple I've got, particularly for the audience we've got on today. During this last 10 weeks, people have been in lockdown. They've been, as you say, following the rules, in isolation in many cases, or self-isolating. Part of that has brought on probably some mental health issues, which we're going to have to both identify and then hopefully treat, help, mitigate. What's your thoughts on that in terms of business leaders and how we come out of this and reflect on that and improve on it?
Yeah, it's really, really difficult. I think there's a number of layers to your question. So 3 types of harm here. Harm from coronavirus, very acute harm and death from coronavirus. And remember, death is only the peak of the pyramid. Lots of people get very sick from this disease and don't die. So people are in ICU for 60 days, or they're in hospital for 2 weeks. And I've got a pal who's a paramedic who's been at home for 5 weeks and still not feeling great. Harm number 2 is stopping the health service to do coronavirus and stopping doing things in the health service. So stopping some cancer surgery, stopping some screening for cancer. So there's harm in there. And then the third harm is exactly what you say, harm from the public health interventions. That could be domestic abuse. It could be kids being attacked in their own homes. It could be mental health of the general population. We are almost certainly making those with mental illness sicker at some level, and we are adding low-level mental health challenges to a broader population. These are 2 different things, and it's important to distinguish them. And the mental health services at a higher level in the health service are now reactivating, haven't ever really closed, but are back, and the waiting times are coming down. So I'm fairly confident, as I can be, that the high end, forgive the shorthand, the high end mental health services will catch up and get the people with schizophrenia, with long-term depression, and we'll get them. I'm slightly more worried about the group who are anxious, lonely, have mental health challenges on a lower but important level across the whole of society. And I think organizations who employ them, who support them, have a responsibility to help us with that. And that might be just reaching out to them. It might be more formal trauma support. It might be using the Clear Your Head campaign, which is the Scottish Government's version of it. I imagine the Institute of Directors has training around well-being and mental health. I imagine there are member organisations of yours who do that, and that's absolutely crucial. Absolutely crucial.
And do you think sharing those good practices, can we pick up anything from other countries in terms of how they have handled the mental health, in particular those anxious, anxiety, depression, loneliness types, rather than the, as you said, schizophrenia? Yeah,
so the Scandinavians are always very, very good and open about mental health challenges and where those people get support from, and it's often from a variety of sectors. So the idea that the National Health Service can solve this is misguided. The National Health Service is one element of how to help, but third sector organisations, family support, churches, other groups, community groups is how these things get sorted, because it's often about purpose and value and loneliness and all of those other things. And it might be as simple as postcards through the doors from the local kids, or just popping your phone number through an old person's home who lives up the road to say, if you need anything, we're here for you. You all know people like that who require that kind of, and I think businesses and boards have a responsibility to reach out to their own people and help them reach out to others.
Absolutely, and it's recognised, and I think the IoD, as well as other business organisations, are promoting this very strongly, that good leaders are going to have to take this responsibility even more seriously than they did prior to this. And as you said, if there's a good thing out of a pandemic, it's the learns that we've got about things like that sense of community and that looking out for each other. I've got one more question before we go on to the questions that have come in from the audience, and it is about leadership. Without straying into the area of politics, unless you particularly want to, it's a little bit sensitive sometimes. Have you spotted globally or in Scotland or in the UK, good examples of strong leaders who have come out of this having made good decisions quickly? And I suppose there's a corollary to that. Have you spotted any? And by all means, don't mention names, but sectors or vague, if you like. Leadership is so important at times like this. What's your thoughts on good leaders, bad leaders?
It's a really good question. I think adaptation and agility are crucial at times of crisis, whatever you want to call it, whether it's a financial crisis or a pandemic public health crisis. So I'm a very, very bad slow runner. So every day I try and do 5K in a little circuit around the house, and it takes me quite a long time, but still it keeps me sane. So as I run, I live in the West End of Glasgow, pretending to be slightly posher than I actually am. And there are some boarded up businesses. There are some businesses that I fear will never open again. I worry about the little gift shop type, fragile economy type places. But there's a couple, as I go around, that there's a little restaurant, a slightly posh restaurant that clearly isn't doing restaurant business, but has set up basically a grocery store in its outdoor space, and it's selling pasta, milk, and some high-end pastries and stuff. Every time I run past, day or night, there's a queue, a 2 meter physically distanced queue. Now I don't know these people. I don't know if they're. I imagine they're not making what they made, and they'll have some employees furloughed. But it seems to me that they've done something about stepping up, given some people some purpose. They're providing a community support, because there's no supermarket within walking distance for the elderly in that particular part of town. So I think even at that small micro scale, people have stepped up. The other sector which I think has done very well, and you may be surprised, is the supermarket sector. I mean, we basically asked the 5 or 6 large scale supermarkets in the country to completely change their business model in about 24 hours. And not only change your business model, but then all these customers who you're used to having inside your stores, we want you to now treat them entirely differently. We want you to set up and we want you to protect your staff while you're doing it. We want you not to run out of stock. I mean, that sector had to literally transform it, much like the health service, pretty quickly. And to my amateur eye, and I've had a couple of conversations with them for advice on how to help them, to my amateur eye, they've played a blinder. They've done very, very well in doubling the number of online. So my mum, who's never done online shopping in her life, at 79 with COPD and almost shielding, so at home all the time, now getting perfectly happily a supermarket delivery once a week, chatting to the deliverer, and that wasn't available to her before, and that's because the supermarket industry has stepped up. And I think they've also changed the nature of the shopping experience. So I think in there are leaders at both extremes of that. And inside the politics, I've been genuinely impressed by the nature of almost every politician who's engaged with me. Some who just reach out and thank me for what I'm doing, some who reach out for advice, some who say what would be a helpful thing to push for, or help us understand the care home outbreaks. We don't need the headlines, help us understand what that really means. And you may be relieved to know that in every political party, there are people who genuinely want to make this better, who want to learn what their role and purpose is in a global pandemic and how to make it better. And that exists at some level in each of the political parties I've dealt with. So I think there are leaders who have stepped up in each of these sectors.
That is very reassuring. And as you say, it's relieving to hear it. Do you think that means we'll be better at handling crises, whether it's a health crisis or otherwise, in the future because of that willingness to step up and learn?
So that's an excellent question. I think there's quite a lot of learning to be done. I think this will define some of our careers for quite a long time ahead, whether that's just because I have to go to 4 public inquiries for the rest of my career, which I'm very willing to do. I hope those public inquiries and parliamentary inquiries and everything that will come will of course look back. Please don't misunderstand me. I'm very comfortable with. I don't do this job without a knowledge that I'll be held accountable. I mean, I completely understand that. But I hope they will be about learning. I hope they will be about preparation for the future, about learning across countries and across sectors, and preparation and how we do that. You can't prepare for a novel coronavirus specifically. I mean, to pluck that out of the air and say that's what we'll get. I mean, the next one could be measles. It could be an ocean emergency. It could be a weather emergency. So you have to have an ability to move within whatever the emergency is. But the nature of how a society behaves, I think there will be deep learning for organizations about how we should do that and how we shouldn't. And we will certainly have made mistakes in the communication, mistakes in the timing, mistakes in the of course. But the only thing I can tell you that I've not been in a room that has said, let's deliberately do this to make it worse. Not once. But the rooms are human beings. I think sometimes social media in particular forgets that the people who are making these choices are human beings like the rest of us, and we're all flawed and we're all trying to do our best in the moment where we're presented with those choices. And that sometimes a little bit hard to take from the ones I've had to mute on social media.
Yeah, no, absolutely. And we're all in this together, I think. I'm going to move on to some of the questions which have been posed from our audience today. And there's one here about the lifting of restrictions on the tourism industry, mooted to be the 15th of July.
Yep.
And how we can handle the specificity of the islands in particular there, either bringing the virus onto the islands from the mainland, but also particularly the transport issues, which obviously going to cause a problem for everyone, but in particular the ferries.
So heavily caveated 15th of July, I should say out loud. If you listen to Mr. Ewing, both yesterday and then on GMS this morning, heavily caveated 15th of July. And we've actually tried not to give indicative dates, because then the world kind of runs away from us. But we've given 2 indicative dates. We've given the 11th of August for schools, and now the 15th of July for the tourist industry. And we've done that because those 2 big sectors, for different reasons, need warning. So we try to give everybody as much warning as we can give, but we don't want to tell each individual sector which date it will be. So the 15th of July is when we hope phase 3 will be, or thereabouts roughly. And that will allow people to move a bit more freely around the country. The virus will be at a level where we're confident that the risk will be lower. The islands are a special case. I've had a number of calls and conversations with the leaders of the islands, with Mr. Wheelhouse, the minister, and others, and we're very, very mindful of virus on and off. Shetland and the Western Isles haven't had a case for 5 weeks, longer. In fact, Orkney just had a new case. So it just opens up the fragility of this situation a little, because you can't close them completely, particularly if we open for tourism. And there's still freight going on and off. We've got people going from chemotherapy from Stornoway to Inverness. So we haven't shut them. We've slowed considerably, but we haven't shut them completely. And then there's intra-island transport as well, because Orkney's not just one island, nor is the Western Isles. So people move around a lot. So I think it's back to our original question. If the 6 levels are met, and it's not, the 6 levels are not binary, but the 6 levels move over time. So the 6 level requirement for next Thursday is 1 level. The 6 levels required for the 15th of July is up a level again. So I would want to see a consistent, sustained reduction in infection rate, in mortality, in ICU admission and hospital admission. And I'd want to know for certain that we were controlling the outbreaks. So fewer or no outbreaks in care homes, no outbreaks in hospitals, test and protect, up and running and catching all the positive cases as they arise. That we anticipate moving to a world where there will be slightly more ad hoc outbreaks. So you might get an outbreak in a working man's club or related to a school, and we'll have to manage them. We'll have to know we're able to manage them, and we're confident we've got teams in place that will be able to do that. So I think the opening of the islands will be part of that process. And the islands is kind of almost a separate sector, a bit like elite sport or oil and gas, and we're having conversations with them. And they're of two minds as well. I'm on these conversations, and one side of the puzzle is saying, open us now, we're ready. And then somebody from the same island is saying, whoa, hold on a second here. So we got to be cautious.
Absolutely. Is a second spike inevitable?
So 2 second spikes. 2 second spikes. The first second spike, which I am actually less worried about, but cautious about, is the immediate second spike. So the relationship with behavior today and last week and the week before. So what will happen if the population do X, Y, Z and the virus runs out of control and the R number goes up? I think we're moving at a pace where I and others are as confident as we can be that we're preventing that second spike. I can't guarantee it. And if it comes up, we'll be back on here and other places saying, look, we went a little bit too quickly. We're going to go backwards. Here's what the new plan is. But we're doing it gradually. We're trying to do it with connecting with the science, but across a population, that's not an exact science. The second spike where the clinicians are more worried about is a spike in the winter. So this virus is not going away. And we anticipate, from what we know of coronaviruses, that there may well be a winter spike. And that winter spike will be more difficult to deal with because it will be mixed in with flu, mixed in with bad weather, mixed in with more old people in our hospitals. It's just a perfect storm. You can't choose when to have a global pandemic, but you wouldn't want a global pandemic in the winter if you could choose. So that's why the science is in such a rush to try and get us some solutions before November, December time. So that's the second spike that keeps me awake at night a little bit more. And I fear that if we get that, we might have to go backwards.
You're saying if we get that, so there is a chance. So it almost seemed from what you just said that it's not going away. Winter will bring with it other challenges. It's highly likely there will be a spike in the winter. No?
Highly likely is probably too strong. So
okay.
A possibility of a second spike in the winter, but layers of protection to stop that happening. Principally, reduce the virus as far as you can. Catch the positive cases, get them suppressed. But also have in place mechanisms like test and protect to isolate out as soon as you get a positive case, get it. Get the asymptomatic connectors to that individual isolated out. Now that is relatively straightforward just now because there's not many people on public transport, nobody's in the pub, nobody's in the restaurants. But let's imagine a scenario in September where we're a bit more open, where we're kind of back to normal maybe. Now the contact tracing becomes much more difficult. And I'm telling you, even though you feel perfectly well, you went to Mother India and the guy at the table beside you, who you've never met in your life, has tested positive. So the bad news is you need 2 weeks off your work. So you need to tell your employer that you're not going to be at work for 2 weeks. You may have no symptoms, but we need you to stay home. That messaging becomes much more difficult.
Yeah. There's a good one here. What advice would Jason give reboosting our immune system, if that makes a difference? And how does he think that increased stress and poor mental health during this has suppressed our immune system?
Yeah, so immune system improvement, I'm afraid, is a long-term mission, not a short-term mission. So it is possible, but you can't do it tonight. So taking some Barocca will not get you through the virus. So exercise, nutrition, and sleep will help you, for sure, to control infectious disease, but it's a long-term mission, not a short-term mission. That doesn't mean that that's an excuse to stay on your sofa for the next 2 weeks. So I would thoroughly recommend good nutrition, exercise every day, and good sleep. And they are the best things for your immune system. And the addition of vitamins or no, just eat normally, unless you have something that requires you to take supplements. Eat normally, sleep well, and exercise every day.
There's a couple of questions here on the test, track and trace system. I mean, we've got the system up and running, as you said earlier. We've monitored 681, I think you said, and got 481 being monitored. Will there be a benefit? Is there a benefit to some of that being available on one of these things with the Bluetooth or whatever technology to enable that to be automated?
Yeah, there are two digital solutions here. Digital solution number one, which we will almost certainly do, is a kind of aid to the contact tracer. So you can, instead of the contact tracer having to talk you through like a detective where you went and who you were with and all, the digital solution will be, can you please tell me, who did you meet? And I say, well, I met Malcolm and we chatted for 20 minutes and I'm sorry to say he is a contact. So I'll enter Malcolm Cannon, I'll put your phone number in, and then the contact tracer will do the thing, just to automate and help the process. So we're almost certainly going to do that once we have that mechanism up and running to help with the boots on the ground contact tracers. The second bit is a proximity app, an app that if two phones are close together, even if you don't know each other, so in the I shouldn't have chosen a specific Indian restaurant, should I? Let's choose an Indian restaurant, and you and I are sitting beside each other. We don't know each other, and we're adjoining tables, and we're less than 2 meters apart. Our phones would know that we were beside each other, and I test positive. You get a message to say, we're really sorry, but you were in such and such a place, and you have been close to somebody who has now tested positive. We need you to go home. We think if we can get that system to work safely, and the data to be stored safely, and it to actually work, and enough of the population used it, it could be an extra layer of protection on top of what we're already doing. We do not require it, because Test and Protect doesn't need it. But if we got it, we would probably use it as an extra layer. There's a big caveat there. Don't believe the headlines. So most countries have not been able to get their population to download it. Singapore, one of the most digitally connected and mature populations in the world, got 17% of its population to download its contact tracing app. So it's a big ask for you and I to turn our phones on in the Indian restaurant, and you see, you're asking the population to do quite a lot in order to help the overall population. And most of the behavioral scientists think you're going to need 60%, 70% of the people downloading it, and that's a big ask.
And do you think that reticence to do that is because we don't switch our phones on in restaurants, which I would query, or because of the concerns about personal data?
I think there are layers. I think it's partly about data. So quite a lot of people saying who the UK government are not having my location. Some of it is because we don't want our private lives exposed. So there's an individual privacy thing. So I may be in the Indian restaurant and I don't want other people to know I'm in the Indian restaurant, for example, or whatever. And then there's a layer of, seriously, I've got no symptoms. The virus is gone. What's wrong with these people? Why are they asking me to do this now? And you see that in behavior already, because so I know people who have had this virus, and I know people who have died in care homes personally, friends and family, but not everybody has that. So sometimes the virus feels abstract. So and my behavior as a 24-year-old university student or a 24-year-old in a manufacturing institute, what do I really need to do this alcohol gel again? I mean, I've not got the virus, etc., etc. And that plays out at a population level, and people die.
Yeah. I think there's another question here. I think you've already touched on this in terms of the comparisons with other countries, but Denmark, Aidan says Denmark seemed to have responded well, both in terms of controlling the virus and keeping businesses open, especially in hospitality trade. Can we learn anything from them? Again, it may be down to population density and diversity and inequalities, but is there something there which is obviously relatively close geographically, relatively close demographically? Is there something we can learn from them either for future pandemics or second spikes or even now?
Yeah, no, there absolutely is. And things now, we've spoken to them often. The other thing they've done, the often quoted Danish example is schools. They've brought their schools back quicker than most others. And the science suggests that children don't suffer severely from this disease, although 26 under 20s have died across the UK. So you need to keep it in perspective all the time. It's not yes or no. So you make judgments and risk judgments inside that. But Denmark has a long history of very good early years education and lots of outdoor activities and lots of investment in those child development centres, they call them. And there are things to learn in there, I think, about what we should do for kids. Their hospitality industry and Sweden's hospitality industry did go back. In fact, Sweden's never closed. My pal who runs a big piece of the Swedish health system quite early on in the pandemic told me he'd been for dinner, a socially distanced dinner in a restaurant in the town he lives in. So they did make choices. They live on the flat. They don't have inequalities or nothing. That's not fair. But they don't have massive inequalities. They don't have much obesity. We have huge obesity, and obesity is, apart from age, obesity is turning out to be one of the principal risk factors of severe disease in this disease. So there are differences, but absolutely we can learn from how they've done it. And just yesterday, I got the weekly graphs of international comparisons from our statisticians, which showed me exactly what each one's done. And then another group of people then work out where are they on their route maps, how does that compare to our route map, and what can we learn about those steps?
You just mentioned age and obesity. I think to most people, there's a logic to those being affecting the likelihood of catching and dying from the virus. Is there any science behind why the BAME community seems to be more at risk?
Yeah, it's a really good question and very complex. So the Public Health England report of last Tuesday looked at risk of disease. And inside that risk, it has a big graph of what are the risky factors, and as much as you can remove, what do you get left with? So the obvious things are obvious: age, comorbidity. It turns out in healthcare terms, this is as much a vascular virus as a respiratory virus. So that means people with diabetes, people with heart disease and heart failure are worse than we would expect, not just people with respiratory disease. Even when you remove what you can from the data, there is still a residual risk left with ethnicity. And it appears to be particularly Bangladeshi and Asian ethnicity, but it is quite small, but residual risk. So even when you remove the comorbidities, you're left with a residual risk. We don't have a scientific explanation for that, although there is some evidence that some ethnicities get vascular disease worse than others, diabetes, heart disease, heart failure, etc., etc. So it may be a consequence of that, or bluntly, it may be racism. It may be that access to healthcare is not as good, access to housing is not as good, access to education is not as good, our communication to tell people what to do is not as good. So it may be structural racism inside global society. I mean, we know that exists everywhere. So why would it not affect our response to a pandemic like it affects our response to every other societal challenge? The Public Health England report doesn't make that judgment. It just exposes the data, and then we have to do our best to make decisions based on that data. The risk is not at a level where we're saying we need to remove the Bangladeshi nurses or the Filipino doctors, or it's not at that level of risk. But we are conscious that we have to do risk assessments around all risk factors, and ethnicity is one risk factor we have to take into account.
Jason, I'm gonna draw it to a close now. We've reached the hour, but one more question. It's from Val. Despite the improved sleep and exercise and nutrition, can she have her deep fried Mars bar as a treat?
Yeah, well, yeah, occasionally only, yes. Although the chip shops, I understand, I did once speak to a chip shop owner about this, and he said they hate them because they have to change the fat every time they do it. So a fish supper once a month may be preferable.
There you go. You heard it from the expert. Listen, I'm going to thank you so much. You've become an absolute superstar during this pandemic. People listen to you. You're very easy to listen to. You're very open and honest, and we really appreciate that. I'm sure the audience would give you a standing ovation if you were in an auditorium. Accept it as if it were, and thank you so much for spending time on a very important day for you. Good luck with this afternoon's meetings as well, and we look forward to meeting you again, perhaps in easier times. But Jason,
thanks for having me, and thanks for both what your organisation does and all the businesses. I realise this is an uncertain time. We probably should have said that at the beginning about how challenging this has been for small and large businesses. And I promise you there are advocates for your industries in all of the big rooms where these choices are being made. They're difficult choices, but they are being made by very, very serious people making tough decisions. I guarantee it.
Wonderful. Jason, many thanks, and all the very best.
Thank you.
Thank you.
Thanks, everyone.
Jason, if you're still there, thanks ever so much, and good luck.
I am. No problem.
And we'll catch up again, I'm sure. But if